Madam, we are live now. Shall we start?
Yes.
So good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all in today's a very important topic that is hypertensive disorders in pregnancy. And our guest speaker is Dr. Mansi Vaish, madam. It's my honor to introduce Madam. Madam did her MBBS and MD in Obs and Gynae, and Madam trained in advanced laparoscopy and hysteroscopy. Madam is the consultant at Meher Hospital, Dehradun. She is the first joint secretary of Dehradun Obs Gynae Society, and Madam done her senior residency from Baba Sahib Ambedkar Hospital, New Delhi. And Madam is the life member of IFS, member of Can Protect Foundation, and awarded the best paper presentation award in 27th AMOGS conference. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please drop your questions on the dashboard of the Shield Connect page. So once the talk will be over, we can have a short chat with Madam. So thank you once again very much, Madam, for your valuable time on our platform Shield Connect and to discuss such an interesting and important topic in Obs and Gynae, so hypertensive disorders in pregnancy. So thank you very much, and over to you for further proceedings. Thank you.
Hello.
Yes, ma'am, you are audible.
Yes, can I start?
Sure.
Yeah. Thank you for the kind introduction, and good afternoon, all the respected seniors and my dear colleagues and all the team from Shield. Thank you for inviting me to talk on this very important topic of hypertensive disorders in pregnancy. This is a topic that increases the blood pressures of the gynecologists also, and we are facing it more and more in the coming times in our OPD practices nowadays. And since in our setup we are dealing with high-risk pregnancy, around 20% of the patients that we are seeing are hypertensive disorders in pregnancy. Now let us see what is hypertensive disorder in pregnancy. Basically, it is a multi-system syndrome being specific to pregnancy and is associated with defective placentation and a widespread endothelial dysfunction with the incidence of being 2 to 8%. Can you move my slides, please?
Madam, it is not moving now.
Yeah. Should I stop sharing and you can share the slides?
Madam, can you please change with your pointer? That is down arrow.
No, it's not changing. So I think, can I stop sharing and do you have the slides to share?
Yeah, just give me a minute, madam. I'll do the share.
Yeah. So I think I can continue talking. Hypertensive disorder in pregnancy can be divided into 4 categories. That is, can be a gestational hypertension, that is just hypertension that is detected during pregnancy, and that is more than 20 weeks of gestation when a patient comes to you in the OPD with the BP of more than 140/90, and this is called gestational hypertension. Yes. Can you move forward? Next, please. Next. Yeah. Further ahead. Yeah. And the second category is a patient having chronic hypertension. That means she was already a diagnosed hypertensive before she was even pregnant, and if she comes to you before 20 weeks and you diagnose that her BP is on the higher side, that is more than 140/90 mm of mercury. A patient can also come to you with symptoms of preeclampsia. Preeclampsia is a condition where there is an increase in blood pressure along with proteinuria of more than 300 milligram per deciliter in 24 hours of urine. The preeclampsia can be divided into severe and non-severe, and it is also has a subcategory which is called the HELP syndrome. The fourth category of hypertension in pregnancy is a patient having chronic hypertension, which is superimposed with having preeclampsia. That is, she starts having features of proteinuria. Then she would be categorized as chronic hypertension with superimposed preeclampsia. Next slide, please. Now, preeclampsia, as I already said, is associated with proteinuria, thrombocytopenia, impaired liver functions. There can be also an onset of renal insufficiency, pulmonary edema, or visual or cerebral symptoms. Next slide, please. Chronic hyper. I think I've already done this. Let's move forward. Forward, please. Yes. Yes. We can move forward. Yes. Yeah, now let us categorize what is severe preeclampsia and what is simple preeclampsia. BP more than 140/90 with proteinuria is called preeclampsia, and it is categorized as severe if the BP is more than 160/110. The patient also presents with a feature of thrombocytopenia, that is platelet less than 1 lakh. Patient also starts having impaired liver functions, that her liver functions become twice the normal. She starts having symptoms like epigastric pain, headache, and her creatinine goes above 0.9. Although in this slide it is mentioned as 1.9 milligram per deciliter, but because the glomerular filtration rate is increased in pregnancy, our threshold for screening of renal impairment has to be reduced in pregnant patients. Therefore, anything more than 0.9 milligram per deciliter of the creatinine going up is an alarm for us that this patient is going into the category of severe preeclampsia. If a patient starts having pulmonary edema, as there is a lot of endothelial damage and our capillaries become leaky, so such patients can also present with a lot of cough. They can have pinkish mucus, breathlessness, which is also a sign towards pulmonary edema. Or they start saying they are starting to have flashes of lightning or blurring of vision. That means there is retinal scotomas also developing in these cases. Sometimes the patient can also have impaired sensorium, meaning that the cerebellum is also getting affected. Next slide, please. Next, please. Next slide, please. Yeah, now we'll discuss the risk factors for patients developing preeclampsia, especially if the age of the patient, either the patient is too young or the patient is too old. If the patient is very young, like below 25 years of age, or the patient is above the age of 35, then such patients are likely to develop preeclampsia. If she's having multiple gestation, like she's having twins or triplets, in such patients also they can develop preeclampsia. And if somebody has a history that, madam, I had PIH in my previous pregnancy, then also such a patient is very likely to develop preeclampsia in this pregnancy. If somebody is already known to have a hypertension prior to pregnancy, then also such a patient can have preeclampsia in the present pregnancy. So somebody having vascular and connective tissue disorders, nephropathies, antiphospholipid syndromes, obesity, and African American race people are also more likely to have preeclampsia. Next slide, please. Next, please. We've already covered this. Yeah. Hypertension affects 12 to 20% of the pregnant patient. Hypertensive disorders is directly responsible for approximately 20% of maternal mortality in United States. And this is higher in our country because there is lack of care, and so many times in the peripheries, the patients are not even able to be detected. Next slide, please. Okay, let's go on to the pathophysiology. What is really happening in preeclampsia cases? There is vasospasm in the vessels. Next slide, please. Prominent finding in gestational hypertension and preeclampsia. Next slide, please. There is inadequate maternal vascular response to trophoblastic mediated changes. and there is endothelial damage. Because of the, next slide please, because of the endothelial damage, there is hemostasis in the vessels, which increases the endothelial fibronectin levels and decreases the antithrombin and beta, please can you go? Antithrombin 3 levels. This allows microthrombi development all throughout the blood vessels, therefore damaging them and making them leaky. Next slide, please. There is an imbalance between the prostacyclins, shifting it in favor of thromboxane 2, which causes vasoconstriction and platelet aggregation. Next slide. Endothelial derived factors like nitric oxide is reduced, and nitric oxide is a very good vasodilator. So because it is reduced, this causes vasoconstriction. Next slide, please. Lipid peroxidase is also increased, which causes oxidative damage to the blood vessels, leading to the further damage. Next slide. Okay, there are a lot of other effects to the other systems of the body. We will go through each system one by one. Next slide. Cardiovascular effects are like hypertension, increased cardiac output, increased systemic vascular resistance. Hematological effects can be, can you move to the next slide? Are in reduced volume, hypovolemia, elevated hematocrit, thrombocytopenia, microangiogenic hemolytic anemia. Third space of the fluid, when the capillaries are getting leaky, so whatever fluid you put in the system, it is going to get leaked out into the third space, and there is going to be hypovolemia. There is going to be low oncotic pressure in the vessels. The neurological effects will be seen as, please move forward, as hyperreflexia, headaches, cerebral edema, seizures, and they can be press syndrome on CT findings. Move forward, please. Pulmonary effects are capillary leakiness, reduced colloid osmotic pressure, and pulmonary edema. Further slide, please. The renal effects is reduced glomerular filtration rate. As I already mentioned, that in pregnancy, the glomerular filtration rate is increased, but in such cases, it can be reduced due to glomerular endotheliosis, which leads to proteinuria, reduced urination, that is oliguria, and acute tubular necrosis. Further, please. The fetal effects can be placental abrasion, fetal growth retardation, oliguria, fetal distress, and increased perinatal morbidity and mortality, more need for NICU stay for the baby. Thank you. Moving forward. Now the management. The ideal management for curing PIH is to deliver the patient. But how do we deliver? We have to assess the gestational age. We have to assess the cervix. We have to see whether the baby will be able to survive after we terminate the pregnancy. What are the laboratory assessments, and how do we rule out whether really the patient is in such a severe state that we need to terminate the pregnancy. Going on forward, moving on forward. So let us discuss about the timing of delivery. If a patient is having chronic hypertension and she does not have symptoms of severe preeclampsia, then we can take her up to 39 weeks of gestation and then plan to terminate or induce her and deliver her. If she is having gestational hypertension without severe symptoms of preeclampsia, then we can take her up to 37 weeks or more. If a patient is having preeclampsia but severe symptoms, severe features like headache, epigastric pain, and she's already 34 weeks and more, then we need to plan her delivery. Further slide, please. And if the patient is less than between 24 to 34 weeks of gestation, and she's having severe features of preeclampsia, the maternal condition and the fetal condition is unstable, we need to deliver her immediately. Sometimes there is not even enough time to give her antenatal steroids. Moving on further. If the patient is less than 37 weeks and a viable fetus, we must give steroids and do not delay the delivery for preeclampsia with severe features like uncontrolled severe hypertension, if she's having convulsions, pulmonary edema, abruptio, DIC, evidence of non-assuring fetal status, and intrapartum fetal demise. Moving on forward. If the patient is less than 34 weeks or 34 weeks, this is the same slide. We can move forward. Yeah. Route of delivery is determined by what is the gestational age, what is the fetal presentation, whether he's cephalic, transverse, breech, what is the ABGAR score for the cervical status, maternal condition, whether the patient is not, if the patient is fine, her saturation is fine, then we can go for normal delivery. If she's having breathlessness, she's uncomfortable, then we will have to go for a cesarean section. And the fetal condition, if the baby is preterm, IUGR, we will have to go in for a cesarean section and not give a trial of labor. Moving on forward. Now, let us see what do we do if we have a patient who is having a convulsion. So magnesium sulfate is the first line of drug, and it is given to patients having severe preeclampsia, and it is not universally recommended. Moving forward. It is not a hypotensive agent. It is basically an anticonvulsant drug that has both a central and a peripheral action. It is given in the dose of 4 grams uh, bolus, which is given over 10 to 15 minutes, and a maintenance dose of 1 to 2 grams per hour. And when you give magnesium sulfate, you have to monitor the urine output and the deep tendon reflexes of the patient, as it can cause the suppression of the heart if it is given in overdose. If the DTRs are reduced or absent, we have to stop the dose of magnesium sulfate. The therapeutic dose of magnesium sulfate in the body is 6 to 8 milligram per deciliter. If the patient is having, suppose the patient comes with a seizure and you send all your blood tests, you have given loading dose of magnesium sulfate, but when the reports come back and you see that the creatinine is 1.4, now when you give a maintenance dose, you have to reduce it to half, because magnesium sulfate is excreted through the kidneys. Okay, moving forward. That we have to also look for toxicity of magnesium. If the respiratory rate is less than 12, the DTRs are not detectable, the patient is in altered sensorium, the urine output has reduced to 25 to 30 cc per hour. So that is the time when need to stop the magnesium sulfate prophylaxis. The antidote for magnesium sulfate is 10 ml of 10% solution of calcium gluconate, which is given IV over 3 to 5 minutes. Next slide. Very few people can die of seizure, but we have to protect a patient who's having seizure. We have to give them a coma position, a left lateral position. We must insert the airway and make sure that the patient is in a safe padded environment. We have to have IV access. Minimum of 2 IV accesses are needed. A magnesium sulfate of 4 grams is given IV over 10 to 15 minutes, and then 2 grams per hour is given over in IV. Next slide. So when we have a convulsing patient, the obstetrician is the one who is also likely to have a convulsion and have a tachycardia seeing such a patient. Moving forward. So, but we don't have to panic. We have to control the situation and give magnesium sulfate, which is the first line of drug. Other drugs are also given, that is diazepam, sodium amyl, phenobarbital, and dilantin, but they are not very effective and they cause sedation. So not usually used. Moving forward. After the seizure, we have to send all the blood tests. We have to see whether the fetal heart rate is there or not. Is it reassuring or not? There is beat to beat variability or not. Now we have to plan the delivery of the patient and see if you can manage it at your center or not. If you can't, then you have to plan how the patient has to be transported to a tertiary center. And Cesarean is not the indication. Like if patient is having eclampsia, it does not mean you have to do a cesarean. If the Bishop score, the cervical status is good, you can also give the patient a trial of labor. That is not an issue. In hypertensive emergencies, we have to do the fetal monitoring. IV access is important. Hydration is important, but we don't have to overhydrate these patients. As the capillaries are leaking, whatever fluid you will put in, it will go in the third space. So we have to give fluid at 80 to 100 ml per hour, and we have to restrict the fluid intake that we are giving. And the reason why we are treating these patients is to save the mother, and we are not thinking too much about the baby as of now. And our aim for controlling the BP is that the BP should come within 100 to 110, and the systolic should go below 160. We have to avoid rapid reduction of the blood pressure, which can impair the blood supply of the baby also. Next slide, please. And I think next slide, we've already covered this. Yeah. Fluid, I've mentioned that you have to give a fluid of 250 to 500 cc of IV. Multiple doses have to be given in rapid succession. Allow time for the drug to work. Maintain left lateral position of the patient and avoid over-treatment. Further slide. The antihypertensives that are usually used are hydralazine, labetalol, and nifedipine. Hydralazine is hardly available in our country. Labetalol and nifedipine, that is what we are regularly using. Next slide, please. The next, we will not talk about hydralazine as it is not easily available. Yeah, labetalol can be given both IV and orally. If you have a IV excess and you are at a tertiary center, you can give IV labetalol, that is 20 mg. Then you repeat the BP of the patient within 10 minutes, and if the BP is not gone below 160, 110, you give a double dose of 40 mg of IV labetalol again, and again you will measure the BP after 10 minutes. Again, if it is not given, then you will again double the dose, that is, you will give 80 mg of labetalol to your patient. In such a case, you can go up to a total of 220 mg of labetalol in one go. Even if after 3 doses of labetalol, then you will have to move to a second antihypertensive. You might have to give a diazepam on a few for a patient to reduce the BP, or another antihypertensive would have to be added. Okay, the onset is 1 to 2 minutes, duration is 6 to 16 hours. It can cause hypertension. It works both on alpha and beta blockers. The drug does cross the placental barrier. It is a category C drug and should not be given in patients having cardiovascular disorders or asthma. Moving forward. Now, nifedipine should not be given sublingually. Previously, it was डिपिन के फॉर्म में आती थी, हम उस कैप्सूल को ब्रेक करके sublingually रख देते थे, which is not the way to go. You have to give it orally. We start with a small dose of 10 mg, and then you check the BP and for after 20 minutes, and then you can double the dose. That is, give 20 mg. You can give up to TID or QID of this dose. It is a calcium channel blocker, but the side effects can be tachycardia, chest pain, and headache. Moving forward. Now we'll move forward because there's hardly any role of antioxidants for hypertension in pregnancy. But as clinicians, we do try to give everything: calcium supplements, vitamin D, folic acid, probiotics, zinc, magnesium, sodium. They've all have had small studies where they show little effect on the hypertension. As clinicians, we try to put in a cocktail of drugs so that we can help our patients as much as possible. Moving forward, please. But so preeclampsia affects 3 to 5% of all pregnancies worldwide. A systemic blood pressure of 160 by 100 on 2 consecutive occasions, 15 minutes apart, means that the patient is having severe preeclampsia. Women presenting with neurological symptoms must be initially assessed and determine the target blood pressure. Avoid lowering the blood pressure too much, as this will negatively affect the placental perfusion. Prophylaxis with magnesium sulfate should be implemented where there is premonitory signs of eclampsia. postnatal women who have had severe early onset preeclampsia should have physician or an obstetrician review routinely at 6 weeks, every 6 weeks. Now, this is a Pritchard's regime, that is the intramuscular regime in centers where we cannot have close monitoring and we cannot have a very good IV access for the patients, where we give 4 grams of 25% magnesium sulfate IV over 5 to 10 minutes, followed by 5 grams of magnesium sulfate, which is given intramuscularly in each buttock. So the loading dose for magnesium sulfate is 14 grams. And in a lot of centers, in a lot of places, we make this mistake that we are only giving 4 grams and we are not giving 14 grams. We generally tend to forget the 5 milligram that has to be given in both the buttocks, which is the total loading dose. And the maintenance dose is 5 grams, 50% magnesium sulfate intramuscularly, that is given every 4 hourly, which is 24 hours after the delivery of the baby. So, but while giving magnesium sulfate, we have to very closely monitor the urine output, the DTR, the respiratory rate of the patient. And if there is any decrease in either of these features, we have to stop the magnesium sulfate regime. Moving forward, please. Yeah, I think I've already covered this. We'll move forward. This is also done. We'll move forward. Yeah. So other complications of severe preeclampsia are pulmonary edema, oliguria, persistent hypertension. Besides giving adequate antihypertensives of different categories, and disseminated intravascular coagulopathy, which is also a very severe complication and becomes very difficult to handle such patients. Moving forward, please. So pulmonary edema, we have to avoid fluid overload. As I already said, we have to give a restricted amount of fluid, 80 to 100 ml per hour, which has to be monitored with a dosimeter or an infusion pump, whichever you have. Reduce the colloid osmotic pressure. Okay, we'll move forward. So avoid overhydration, restrict fluids. Lasix can be given 10 to 20 mg. IV can be given every 6 hourly. Usually there is no need for albumin or heta starch. Moving forward. So oliguria is, we say oliguria when this patient is having a urine output of less than 25 to 30 cc per hour. And in such cases, first we have to give a fluid challenge to our patient. That is, we give fast, that is 250 to 500 cc of fluid we have to give our patient fast. And if also, then also if there is no urine output or it is reduced, then we will have to look in whether the renal functions are impaired or not. And Lasix is not necessary. We try not to use Lasix, especially if the patient is antenatal, because postnatal period diuresis commonly occurs. Persistent oliguria almost never requires a PA cath. Next slide, please. BP may remain elevated for several days. Diastolic BP less than 100 do not require treatment. By definition, preeclampsia resolves by 6 weeks. Next slide, please. DIC rarely occurs without abruptio. That means if the patient goes into DIC, she's likely to have abruptio. There's going to be low platelets. There's required replacement by blood, and cryoprecipitates and FFPs will be required to manage such patients. Moving forward, please. So continuous lumbar epidural is preferred if platelet is normal. Need adequate prehydration of 100 cc. Level should be always be advanced slowly to avoid low BP. Avoid spinal with severe diseases. Moving forward. So what is HELP syndrome? It is also a type of severe preeclampsia where there is hemolysis, there is elevated liver enzymes and low platelets. Moving forward. It is Yeah, I've already mentioned, and the liver enzymes can be raised more than 2 times. So low dose aspirin, that is 75 milligrams, is recommended in patients with a history of early onset preeclampsia and delivery less than 34 weeks of gestation. Preeclampsia is in more than one prior pregnancy. So if there's a history that the patient had a preeclampsia in a previous pregnancy, you should start with aspirin 75 mg early in the early stage of her pregnancy, or you think that she has a history of genetic history of hypertension in her parents, then also you can start with aspirin. Moving forward. Uh, Low dose aspirin is not effective for low risk patients. Calcium, vitamin C, vitamin E supplementation is generally found to be ineffective. There is no compelling evidence that any of these are harmful, though. Moving forward. To summarize, criteria, we have to first diagnose our patient properly. We have to send laboratory tests, assess the baby by ultrasound, by NSTs, by doing uterine artery Dopplers. We have to assess the fetal condition, biophysical profiles, the AFIs. The baby has to be properly managed and assessed. And if the patient, you feel that the patient is going into severe preeclampsia, she starts having features of low platelets, she starts having headache, she starts saying, ma'am, I'm having blurring of vision, if there's epigastric pain, then you will have to start with, or hyper reflexes, like the deep tendon reflexes are just flying, then you will have to start with magnesium sulfate prophylaxis. And after you start with magnesium sulfate prophylaxis, you have to deliver your patient within 24 hours. And the mode of delivery has to be assessed by seeing the condition of the mother, the cervical status, and how fast you want the delivery. Moving forward. Next slide, please. So there are certain foods that they say that's good for, you can add, like foods rich in vitamin C, like grapefruit, oranges, lemons, pumpkin seeds that are rich in magnesium, potassium, arginine, beans, lentils, berries, pistachios. These are very rich in carotenoids, these magnesium and potassium. All these beans are very rich, which can be added in our diet. Broccoli, which has flavonoid antioxidants, can also be very helpful. And herbs and spices, chia seeds, flax seeds, beetroot juice, and spinach is all that we can suggest to our patient, because patient will be very helpless and say, ma'am, what to do, can you suggest us something? So these are certain food supplements that we can suggest our patients. And there is no harm in taking all these supplementation and antioxidants and multivitamins, because it will only add to the health of the mother and the baby. Thank you so much for your patient hearing. And I hope we can have some good questions.
Thank you very much, ma'am, for this nice presentation. Just give me 1 minute time to check if any. Madam, one question is if there is any toxicity with magnesium sulfate.
Yes.
So how to combat that situation?
Yeah, I think I already talked about the antidote, that is calcium gluconate. 10 ml of calcium gluconate is given over 3 to 5 minutes, and it is given IV. That is an antidote for magnesium sulfate toxicity.
Thank you very much, ma'am.
Yeah.
Ma'am, one question is, does aspirin prevents preeclampsia or not? What is your opinion from your practical approach?
Aspirin will not prevent preeclampsia, to be honest. Aspirin will only help to improve the circulation. And it will help to prevent the endothelial damage. So it cannot prevent the preeclampsia, but it can help to present like delayed presentation. Like you will be able to take your pregnancy at a viable state where you'll be able to easily and safely take out your baby.
Thank you. Thank you very much, ma'am.
It has a supportive role. Yes.
And one question is, ma'am, that is calcium and vitamin D3.
Yes.
So how it is effective in preeclampsia, and when to start exactly? Which trimester if you find a patient with a
Calcium seen by in the first 3 trimesters, patients are generally having so much vomiting that they are having so much gastritis that they're not able to have. But if they can take calcium in the form of milk and dairy products or in soya bean products from first trimester onwards, that is very good. And we start calcium supplementation from fourth month onwards only in our private practices. And calcium is very important as it helps in the maintaining the endothelium of the blood vessels. So calcium and vitamin D are very important for that. As the whole pathology of the preeclampsia lies in vasoconstriction and the endothelial damage. So calcium and vitamin D are very essential for maintaining the endothelial integrity. Can you hear me?
Yes, yes, yes. Thank you very much, ma'am.
Okay.
And in patients with no severe features of preeclampsia, is there any guidelines to deliver the means when to deliver, or is there any recommendation from that?
If there is no severe preeclampsia, we can take our patient up beyond 37 weeks of gestation. If there is, and the mother and fetal conditions are fine, there is no uterine artery and diastolic changes in the baby is fine, the mother is not having any severe symptoms like headache, epigastric pain, or sudden edema in the body, then we can continue her beyond 37 weeks of gestation.
So thank you very much, ma'am. I could not find any other questions. So
Okay,
thank you
thank
once
you so
again for
much.
your valuable time to talk
Thank
on this very important topic.
Yes.
And in future also, we look forward for some valuable session with you.
Yes.
So
Thank you.
very
Thank
much,
you
ma'am.
so much for inviting me, and sorry for the disturbance in the middle. My son also wanted to hear the topic. He was very curious.
Thank you so much, ma'am. Thank you so much.